What's going on, guys? Welcome back. Dr. Andrew Fix here on the Code. Thank you so much for tuning in, joining us on this podcast today. However you're tuning in, know that we appreciate your time, whether you're in the car, at home, audio or video. Excited to be bringing another interview to you guys today. We are meeting with Dr. Kevin O'Donnell with an office here in Colorado called Breakthrough Regenerative Orthopedics. And Dr. Kevin's a non-operative sports medicine physician, and he specializes in biorestorative and regenerative treatments for acute and chronic musculoskeletal conditions. And we'll probably get into it on this podcast, but I've been a client in their office, worked with Dr. Kevin, and we're excited to have him on the show. So, Kevin, thank you so much for joining me on the Code.
Thank you, Andrew, for having me.
Absolutely. Well, we've been planning this podcast for a long time. It's just tough to get two schedules together, but we're excited to talk about some of these things because this is a growing area of medicine, I feel like. And like I said, I've done a procedure with Kevin. And why don't we start with this? If you could just do us a favor, Kevin, just give us a little bit more of an introduction of you and tell us a little bit about your background.
Sure. So I'm a physician. I was initially trained in Pennsylvania as a family doc. I actually worked for about 4 years in the U.S. Air Force doing strictly primary care. So soup to nuts primary care. And one of the things that I really liked about being in the military was in primary care, physicians see pretty much everything from heart disease to diabetes to hypertension to musculoskeletal injuries. And our background and training is how should I say this, is a little bit underwhelming when it comes to musculoskeletal. And when I was in the Air Force, that was a lot particularly with the active duty patients. I saw a lot of those, and I actually became quite interested in that field of medicine, despite the fact that it really wasn't my specialty. And I glommed on to some of the orthopedic surgeons while I was there. And as it turns out, I got a lot better at treating them because they were busy. The Air Force was overtaxed at the time. We were going through 2 wars, and they needed somebody to see the things that weren't directly or obviously operative at that point. And so it became kind of my niche there. And as it turns out, in primary care, there is a subspecialty called primary care sports medicine. And so it's a year or 2 fellowship that you can get as a family physician. And I decided when I was there, I fell in love with it. And after I got out of the Air Force in 2008, I went to Toledo, which is a very highly respected, University of Toledo, highly respected primary care sports medicine fellowship. And I was thrown to the wolves, covering teams from football to basketball to baseball, working in a sports medicine clinic. And like I said, I just really fell in love with that and learning everything there was to do from a non-operative standpoint.
Yeah.
Subsequently, I decided that I wanted to sort of forgo the primary care or general primary care. And then I was employed by an orthopedic practice in Flagstaff, Arizona, and I was there for 12 years. And they really brought me on initially to kind of evaluate acute injuries and sort of chronic, obviously non-operative things. And I ended up finding myself in a situation where I was referred to physical therapy, giving braces and shooting a lot of steroids into patients. And if they didn't get better, I sort of threw my hands up, and then I would refer them off to the surgeon, whether or not they were sort of appropriate or not appropriate for surgery. A lot of them ended up getting surgery, and a lot did well, but a lot didn't too. And I just was like, there's got to be something else for me to do in this field.
Yeah. It's so interesting to hear, kind of the change of course, or the trajectory that you had there, going from the primary care, but then finding that niche where you're sort of doing a lot of that non-operative management and assessing people. And that makes sense from that military background with, I mean, we hear that even still now today, like military docs are overwhelmed with the number of folks that they're trying to work with. And whenever they can have a few more resources to, hey, go see this person, hey, go see this person, because we've got too many people to manage. It makes sense that you're able to carve out a little niche there. It's interesting that you mentioned Toledo, because I'm pretty sure one of the instructors in my physical therapy school education actually went to Toledo as well, and did some of their training there. So yeah, great program. So when was it that you were in Flagstaff? You said you were there 12 years. When was it that you moved here to Colorado?
Yeah, so I came here actually during COVID. I was in the orthopedic group, and I got into what we'll talk about here. I got more into the regenerative medicine treatments, and just really decided that being in a practice with 8 other orthopedic surgeons, our goals weren't, I shouldn't say our goals, but the way we looked at things. I was orthopedically trained, like I mentioned, and looking at everything, as an orthopedic surgeon, but from a non-operative standpoint. And during probably starting in about 2009, I started dabbling in some of the regenerative treatments. Like I said, I was a little bit frustrated with kind of the traditional non-operative options, meaning on my menu, there wasn't a really huge amount of things that I could do. And then I started dabbling, fell in love with doing regenerative medicine, was seeing the great outcomes I could have and keeping people out of surgery, which most people want to avoid if they can. And so as that part of my practice grew, it just the alignment of the goals and what I was trying to do, it was just kind of, I wouldn't say necessarily putting a wedge in the group, but it was separating me as somebody who was going off and kind of doing things that they didn't really understand necessarily because it was new and was a little bit maybe at odds of the mission of the group. So during COVID, when we all had downtime, my wife and I decided that, hey, you know what? Let's get back to Colorado, where she's from, and let's find something where you can do this full time or mostly full time. And so it's been a great decision. And so I did a year actually in Charlotte, North Carolina for a year at a stem cell clinic. And then the goal was always to get back here to Colorado. Didn't really find anything that was really going to work for me at that time. But I was there for a year, got some good training on some various aspects of what I do. And it was good. It was a great year for me. But my wife always wanted to come home. And so we've been here since 2021. My practice is in Centennial, and it's called Breakthrough Regenerative Orthopedics. And we're a smaller group with 2 locations, one in Boulder, one down here in Centennial. We have 3 docs, and I'm a single doc down here, kind of a low profile practice with very caring people. We see a maximum of 10 people per day, and we try to give concierge care to folks and really spend time. Our initial visits are 90 minutes, our follow-ups are 45 minutes. So we really get to understand, first of all, what's going on from a diagnostic standpoint, having the time to talk to patients about what we do, because a lot of patients are kind of unfamiliar with a lot of the offerings that we have, and be able to talk them through their various options, whether it's physical therapy, bracing, regenerative treatment, or surgery when appropriate. And so we've been doing that for a few years now. Things are going well, and I think it's the best decision I made.
Awesome. Yeah. I mean, so many people, whether it was during COVID or elsewise, Colorado is a very common place to relocate to, that's for sure. But something like what you said that I really resonate with, because I think it's also part of the whole reason that myself, my wife, and now our son Aiden, like why we are out here is because of the same thing, like, starting to dabble in learning other areas of how to approach things. Like for me, it was starting to get frustrated with the traditional model of healthcare and the traditional model of physical therapy and seeing, 16 clients a day that are all overlapped and you don't get one-on-one time with really anybody. You're taking a bunch of documentation and notes home, and you really don't, I wasn't feeling like I was getting to work with people throughout the full scope of like truly getting them back to back and exceeding the level that they wanted to be to. We were like, we're discharging clients because their insurance has run out of visits, or workers' comp doesn't want to pay, or whatever it is. And I was just starting to get frustrated. So I started to dabble in some of the more out of network cash pay physical therapy. And then honestly, in a lot of just the fitness and exercise side of things, I started doing some personal training on the side out of the office. This was pre-COVID, but then continued on. And then wanted to start working with some clients in a more performance manner in the office that I was in, and kind of got shot down on that. And I said, I don't understand. This is a way for me to bring in cash paying clients that wouldn't be here anyways and use this facility to do it. They're like, well, that's not like what our focus is, right? We're just focused on getting referrals from the physician to fill up our office and treat clients. So I was like, all right, well, my wife and I started looking for something else, and here we are. We're out here in Colorado, just like you. I would love for you to, sort of explain to us a little bit, because I think what you said about your menu of service options to help clients or to use as a way to work with clients just didn't have some of the things that you wanted to be able to do in that practice. And that's one of the reasons that you stepped away. And I feel like this is a common thing that I hear in the office, or people probably feel, is they go to the physician's office, the orthopedic specifically, and they might get presented with a set of options and they don't really like any of them. And they're like, it's surgery, it's an injection, or stop doing the activity that is causing you the symptoms. And then you won't have knee pain if you stop running. Like, why do you think it is that, like, sort of that's the way that sometimes our orthopedic experience is from a client perspective?
Yeah, that's a huge question. I have a lot of thoughts on that. First of all, in all due respect to my orthopedic surgical brethren, they're really taxed at this point. I think back to when I was in the orthopedic office, we're taking insurance and seeing 25 to 30 people a day and double booked 15 minutes. And
Yeah.
I really look back and I wonder how I did it. I know how I did it. I gave the best I could, but you walk away at the end of the day and you feel like, boy, was I really able to help someone in a meaningful manner in that period of time? Now we talk about all the things that go into healing, right? We talk about nutrition, we talk about supplementation, we talk about bracing, we talk about why we do things, we talk about the science behind what we do.
Yeah.
And but the why I think that that's the case is that the bottom line is that surgeons get paid to do surgery. I mean, that's their bread and butter. And so how the surgeons look at things is they do surgery very well. So if you need surgery and you go to a good orthopedic surgeon, you're going to get well taken care of.
Yeah.
And they're very highly skilled and smart people. But when it comes to non-operative care, they're I think woefully inadequate. They give lip service to it, and their real goal is to get rid of pain. So that's why steroids are so abundant out there. If I could get someone feeling better, it's not surgical, I could get them feeling better and out the door in 10 minutes, then they're going to be happy, at least for a short period of time potentially. And so it's very much focused on the end goal of surgery, and rightfully so. That's what they do, and that's kind of the model.
Yeah.
But there's this big piece missing, Andrew, where that people have options, and just quite frankly, you don't have a lot of time in that amount of you don't have a lot of space in that amount of time to be able to talk people through what their options are, what are good options, what are bad options, pros and cons of each. And so I think it's just evolved that way, rightly or wrongly.
Yeah. Yeah. I think that makes a lot of sense. It sounds, from the orthopedic angle, very similar to the physical therapy angle. It's like the system is not set up to to give providers a lot of time with clients, and not set up to encourage those providers to be like experts in a lot of different facets of all the different options that are out there. You know, we only have a short amount of time to just try to get this quick outcome. And it's so interesting that you mentioned, like, you know, one of the goals is just to get people out of pain, because my father just had a orthopedic experience where he's got prior history of a rotator cuff repair on his shoulder. He has more tears that are present in there now. He has a lot of strengthening that is necessary to do. And he's starting to have some pain again with activities. So he went and saw the ortho. Truthfully, they really like want to replace his shoulder, but he doesn't really want to do that. So they gave him an injection, corticosteroid. It did definitely help reduce the pain. So then he went back for a follow-up and said, hey, it's actually feeling a lot better. I'm in therapy. It's starting to seem like I'm getting a little stronger. And they actually, even though he said, it's not hurting, I'm in therapy, I don't want surgery, they offered him another injection in that appointment. They were like, well, we can do another injection. And he was like, well, what would the purpose of that injection be? My shoulder's feeling a bit better than it was before. They're like, well, you can do an injection up to every 3 months. And he was like, no, I don't think I need to just keep coming back for injections. I think I need to keep rehabbing the shoulder. And if we want to go down the surgery route, if we think it's appropriate in the future. But I thought it was just interesting that they just made sure to let him know, hey, you can do an injection every 3 months if you want to. So he was like, no, I'll keep rehabbing it. So it's one of those things where when you can find a provider that is able to spend the time with you, like you just said, you guys are seeing 45 to 90-minute long appointments, which is really remarkable in the medical system today, especially on the physician side of things. I feel like it's really a cool service for clients. But let's start talking about what some of those different like regenerative options are out there for people. So like we know when is necessary, surgery definitely has a time and a place, right? If you're a young youth athlete and you're in the peak of your career, or you're a professional athlete or something, you tear your ACL, man, you probably want to get that reconstructed so that you can get back on the playing field or court or whatever and continue to perform at a high level. You have just such advanced arthritis, you've tried a lot of things, maybe you do need a joint replacement, right? We have these things, the technology is there, and there is a good time and a place for some of these options. But what else are some of the options? Like, what are some of the regenerative techniques that that you guys specialize in your office?
Yeah, so when I look at an injury or a chronic issue, the first thing that I ask myself is this a structural issue or is this a biologic issue? And what I mean by that is the person who comes in that has advanced knee arthritis, they have severe malalignment, and you get an MRI on them, and their bones are just crushed together. They're bone on bone. They have a ton of edema in the bone. I can maybe do some things that will help mitigate that pain, but that's really more of a structural issue at that point. The joint is destroyed, and that's really where orthopedic surgeons come in, where they can actually replace the joint. The majority of the patients I see, though, don't have severe structural issues. A lot of it is biologic. And when I was in medical school, and sadly a lot of people still believe this, I was always taught that arthritis of a joint was analogous to wear and tear.
So glad you brought this up so that we can have this discussion.
Yeah, let's talk about it. Wear and tear akin to like your tire. You get a tire, and then after 80,000 miles, it starts to become bald. That is not at all how osteoarthritis from a pathophysiologic standpoint works. Arthritis and a lot of even the soft tissue injuries are really mitigated by the biology of the tissue itself. So arthritis is really, we're finding out more and more. We don't really know why people go from a normal knee to starting to get arthritis, but we do understand the underlying process, and it seems to be related to inflammation first and foremost. So folks with either bad diets, with history of trauma, obesity, and people without those things for that matter. But what seems to happen is the joint gets flooded with these chemicals called cytokines. And these pro-inflammatory cytokines start to develop inside a joint. And what that does to the joint, first of all, the nerves inside the joint, they get aggravated by these pro-inflammatory chemicals. That's why it hurts. It irritates the lining of the joint called the synovium. And so a lot of times you'll see somebody with osteoarthritis who's got a bunch of fluid in their knee. That's what we call a synovitis. So the synovium gets aggravated, and that reacts by pumping out more of the normal fluid in the knee. So I tell people that have a knee joint effusion or fluid in the knee that it's normal fluid. It's just an abnormal amount and highly inflammatory. And then after months of years, Andrew, of this sort of witch's brew hanging out in their joint, that's what eventually creates an immune reaction that eats away at your cartilage. And so when you get an x-ray and you say, oh, look, there's a joint space narrowing or you're missing cartilage there, the whole underlying process isn't wearing of a tire. It's this underlying biology that manifests itself in the joint. And so what we do with regenerative treatments is really try to target that biology of the joint or the soft tissue, and we can talk about that in a second. And we have various ways that we can do that. You know, what I do from a regenerative standpoint is I don't do surgery. I think that's been clear. But we inject substances into the joint to help either flush out some of those cytokines, to stimulate a pro-growth environment inside the joint. And, you know, the main ones that we do, the main treatments we do is something called prolotherapy, which is a dextrose treatment, PRP or platelet-rich plasma, and then we do stem cells. And really, the way that you look at this is that we're putting growth factors or a combination of growth factors with stem cells in an environment. Stem cells have the ability to actually recognize an environment as being off-kilter or pro-inflammatory, and stem cells are amazing. They can actually reprogram that joint, drive down those pro-inflammatory cytokines, increase the growth factors, kind of to reboot the joint or the tissue back to its native state, or encourage healing of that. So I said a lot there. So
no, I love it. And we'll dive into each of those, like kind of three subcategories that you mentioned.
yeah.
Prolotherapy, the PRP, the stem cells. But I love that you just started to take us on this understanding of arthritis being much, much more than a wear and tear problem. Because I agree with you, when we talk with clients in the office or we see things online, we talk with physicians, that is still, I think, what the normal understanding is out there in society. And we know that if we can help somebody that has arthritis, right? Their cartilage is already worn down, they have moderate to high levels of arthritis, we can change their symptoms by doing things like improving their sleep, improving what they put in their body, their diet, their nutrition, whatever word you want to use, reducing their stress in their life, whether that's work stress, family stress, financial stress. If we can find a way to improve their stress picture, we can change their symptoms, because all those things can affect the level of like chronic inflammation that is in the body. Which is responsible, like you said, for a lot of why that joint is irritated in the first place, is that environment that is present within the joint. So it's much, much more than just the wear and tear. But then when we take things from the mechanical angle, if we can make people more mobile, stronger, more stable, then even if they have arthritis, their joint is more well supported from a musculoskeletal standpoint. We can really do a lot for these people. But say someone does come into your office, right? And maybe we'll ask you this question, like, what are some of the most common things that people come into Breakthrough for, and like most common ailments that you end up treating clients for?
Yeah, it's a great question. I just want to touch on something you just said, though,
Yeah.
about inflammation. We're finding, and this may not be obvious to all the listeners, but we're finding that inflammation is really the critical component of a lot of our chronic disease that we get. We talked about it from, you know, an osteoarthritic standpoint, but if you look at really any of the top killers of Americans, really inflammation. So cancer, heart disease, diabetes, strokes, I mean, you name it. It's all mitigated or caused by inflammation. And so this is relatively recently been recognized as an important component. And so we talk to folks about what are they putting into their body? How much are they exercising? Are they doing any supplements or nutraceuticals to reduce whole body inflammation? Because beyond your knee or your shoulder, for that matter, the things that are going to put us to an early grave are all related to this inflammation. And so I try to stress to patients that not only is this going to help probably with your knee pain, you're doing yourself a good service in your general health by, as you mentioned, getting good sleep, staying away from processed foods, eating a clean diet, getting regular exercise. I mean, this is all kind of basic things, but study after study has shown that if you're doing those things, your risk of death goes way down. So
Yeah.
sorry to delve off into that.
No, I think it's great because all the people listening to this have heard this conversation before. Like, this is a theme on this show. However, it's still very challenging to do. Like, it has to be an ongoing practice that you put into place every single day, because those things, like just speaking of the food or of the fitness side of things, those things are not easily accessible to us. Like, it is so easy to eat poorly because that stuff is available right at your fingertips right now, and it's made to taste a certain way that you want more of it, and it's not good for you. It is so easy to do things like take elevators, escalators, whatever, that don't make it challenging for us to like actually work on our fitness and our health and get stronger and more mobile. It's so easy to sit on the couch and watch Netflix instead of go out for a run or go do whatever. So I think it's just so important to keep bringing up. So I appreciate you doing that.
Yeah, I mean, I read something the other day. I think it was on Twitter, but it said you don't exercise to not feel guilty about crappy stuff you eat. You exercise because you're able to, and because you can, and because it's good for you. And a lot of people look at it as exercise as kind of the price they have to pay for leading a bad lifestyle. Does that make sense?
Yeah.
But as we get older, and you well know this, senescence of cells is what we're really fighting about. What we're fighting, right? So if it's that old adage, if you don't use it, you lose it. And we as you know, you lose muscle mass as you get older. And the number one reason people go into nursing homes is because they can't do a quarter squat to get off the toilet, and they need help doing that. And so I think this is vitally important for folks to understand that this is a lifelong commitment, particularly if you're interested in longevity. Getting some aerobic exercises, super important. But as we get older, really getting the resistance training, I think, in generations currently and previously, they never emphasized. And I think you'll find that as people have become more active in the older ages, people are just going to live longer and longer and longer. And so regardless of whether your knee hurts or your shoulder hurts, just making that part of your lifestyle, you're going to heal better, you're going to live longer, you're going to feel better. And maybe I'm saying obvious things here, but it's really dawned on me over the past several years how important this is. And I'm 52, and I'm going to continue to do resistance training to prevent this from happening.
Yeah. Well, we'll keep. We'll keep exactly. Sarcopenia is not waiting around for any of us. It's going to affect all of us if we don't do something about it. Well, we'll keep beating on this drum as we go. But you mentioned that prolotherapy, PRP, and stem cells are three of the big regenerative types of treatments that you do. But then I had asked you, what are some of the most common issues that people are coming into your office with? Like, what are the most common things you treat?
Yeah, I get back to the original question before I went out on my tangent. So I really see anything from toes to nose when it comes to whether it's a joint issue, a tendon issue, acute muscle tears, ligamentous injuries. So I'll give you some examples. So things like rotator cuff tendinitis or tendinopathy, osteoarthritis, really of any joint, I see a lot of tennis elbow, plantar fasciopathy or plantar fasciitis. We see a lot of Achilles tendinopathies. Yeah, really, a lot of the things that that most of us will deal with at some point in our life, we're able to successfully treat. I would say probably the number one thing we see is osteoarthritis followed by chronic tendon injuries. We
Yeah.
see a lot of spine here as well, ligamentous instability of the sacroiliac joint, facet arthritis, the lumbar spine. So really, it's fairly well-rounded
Yeah.
practice. I don't specialize in one joint or one particular issue, so keeps it fun too.
Yeah, and I think those two things, most people listening to this probably can relate to. I think we have probably a pretty active listener population here on the code, and whether someone has dealt with arthritis or knows some osteoarthritis, that is, or knows somebody who has, most people probably have dealt with some form of a tendinitis or tendinopathy, like an overuse irritation or sometimes I hesitate to use the word overuse. One of the reasons we developed these tendon issues in the first place is a capacity issue. We did not have the capacity, the strength and the resilience of that tissue to tolerate the demands of what it is we were doing. So in that sense, I guess you could say it's overuse, but somebody doesn't necessarily have to have done a lot of an activity to develop a tendon complication if that tendon just simply was not able to withstand even a basic activity. Maybe they played tennis one time and they developed a tendinitis of their elbow, for example. But I think those two things, we can round out a pretty good discussion on those because I think most people can relate to them. So, like if someone comes in your office, and why don't we use tennis elbow as an example, since we just brought it up, and it's spring and moving into summertime here in Colorado. A lot of people are out there playing tennis. Um, what does that sort of assessment normally look like? And then let's start to talk about prolo, PRP, and stem cells, and how do we implement these things to potentially help some of these issues people are dealing with?
Yeah, so when I think first we have to differentiate between a tendinitis and a tendinopathy. The majority of what I see is more classified as a tendinopathy, which is not a great term. Tendinosis is probably the best term. And so what we're talking about is you go out and play tennis for the first time in 10 years on a Saturday, and you wake up Monday morning and your elbows red hot, swollen, extremely painful. That's more likely what we call a tendinitis. Itis denotes inflammation. And so that's kind of more of an acute inflammatory reaction to, as you were saying, to tissue overload. We tend to treat those, conservatively with, things like anti-inflammatories, ice, relative rest. And the good news is that the majority of those patients will get better and do just fine. But what happens is when these become something that comes and goes or lasts for greater than 3 months, the idea of this sort of spontaneously getting better with doing anti-inflammatories and ice and so forth really, really goes down. And what happens is there's a conformational change in that tissue where initially with a tendinitis, there's a lot of pro-inflammatory cells. If you looked under a microscope at a really acute tennis elbow, you're going to see a lot of inflammation in there. But as we get longer on in these treatments, if you looked under someone who's had this for 6 months or a year or something like that, there are very few, if any, inflammatory cells in that tissue. And what you will see is disorganized collagen fibers, with a lot of what we call ground substance, basically unhealthy tissue that is disorganized and looks completely different than normal tissue. And this is more of a degenerative tendon issue or a tendinosis. And so, whereas the first example we treat with anti-inflammatories very appropriately to do, when we get into tendinosis, we don't treat degenerative tendon issues with anti-inflammatories. It doesn't make sense on a level, and that's why people tend to not get better by just doing those things. And so what we want to treat that with is regenerative medicine. And physical therapy is a great example of that. I mean, physical therapy, what you do every day is a regenerative medicine. What you're doing is, you're trying to calm down the pain, but then your goal is to progressively load that tissue, right? To stimulate a healing response. And so that's the appropriate way of doing that. Now, when we do regenerative treatment options, let's say they saw Dr. Fix, and they've been doing physical therapy for, they've been doing everything we just mentioned, doing physical therapy, and they're just not getting over the hump. In other words, they're not responding alone to physical therapy. That's where someone like myself comes in. And really what we're doing with the treatments, and I can go into each of these if you like, with prolotherapy, platelet-rich plasma, or stem cells, is we're really trying to take this chronic non-healing injury. And so let's talk about prolotherapy. So prolotherapy.
Yeah, and before you jump into that, I think, just because of hearing you say it and whatnot, we use, and hearing it be one of the more common things that you guys end up treating. We're using the example of tennis elbow, but really, I think, just to make sure everybody's clear on this, like, this is in relation to any tendinous related issue, right? This could be the Achilles, and we could talk about my Achilles if we want to. This could be your knee, your shoulder, your elbow. Like, this is not specific in any way just to tennis elbow or any other condition. This is just, we're talking about how the tissue responds, how the tissue heals, how we should manage these types of conditions, regardless of where in the body they are. So yeah, just wanted to throw that out there. But yeah, let's what the heck is prolotherapy? You said it's a dextrose-based treatment, but tell us a little bit more about what that is.
Yeah, so prolotherapy has really been around, if you really want to take it back, since the time of Hippocrates. So people, there's some stories of Hippocrates where people that had instability of their shoulder, and what he would do for that is he would take a red hot poker. I don't do this, by the way, and jam it into the shoulder capsule. And what they were doing there was stimulating acute inflammatory response. The goal was to get that to scar down, lay down new collagen, and kind of tighten the shoulder. So that's the old prolotherapy. And then in the 50s, there are two doctors, Hemet and Hackwell, that started dabbling with kind of on the idea that when we're treating chronic tendon injuries, really our goal is to turn over that bad tissue into good, healthy tissue. And the way that your body normally does that is by stimulating an inflammatory response, stimulating an immune response, attracting the cells that are necessary for repair and regrowth to that area. And so really what they started dabbling with was getting things that were otherwise safe for your body, but that created an inflammatory response. Over the years, there's been multiple substances used for this, from cod liver oil to pumice, but nowadays, I say the vast majority of us use dextrose. And so dextrose on a cellular level creates what we call osmotic cell death. So you put a hypertonic dextrose, usually anywhere from 15 to 25%, depending on the tissue. And what it does to the tissue is I don't want to get too technical here, but it causes water to rush out of the cells of the tissue. If you think back to chemistry, your body wants to equilibrium there between the outside the cell and inside the cell. But basically what you're doing is you're putting a hypertonic solution around a diseased tendon. It causes what we call osmotic cell death, and really stimulating that repair mechanism to go on. So we're kind of tricking your body into thinking that there's a new acute injury there for something that wasn't doing a great job of healing on its own. Yeah. And so that's prolotherapy.
Yeah, I like that. And it sounds like, even years ago with the hot poker story that you told, like, that seems to pair really well with something that we use in our office, or many physical therapists and other providers do, like dry needling, right? Of course, we're not injecting anything. That's why it's called dry needling, but we are trying to create small amount of micro damage and create a new inflammatory process to give the body something to respond to and something to try and promote a healing response to. And in a otherwise healthy person, not somebody who is smoking a pack of cigarettes a day, or not somebody who's an alcoholic, like these things don't work as well in those people because their body's not quite as ready for that great healing response. It's an unhealthier situation. But yeah, that seems to work great with so many clients. It's a great tool. And this is just a different version, injecting something to create that chemical change within the body, which takes that a step further.
Yeah, it's so when you're doing this, you're obviously using a needle. So kind of like you do with dry needling, you're as you said, you're kind of poking holes in the tendon, creating a little localized bleeding in that area, and then you're kind of supercharging it, I guess, with that extra chemical reaction that you described.
Yeah. So how does prolotherapy differ? And I guess I'll ask another question. How does prolotherapy differ from PRP, which we're about to get into next?
Yeah.
And would you say that these things we're talking about, prolo, PRP, and stem cell, tend to be used kind of in a escalating fashion, like
That's right.
prolotherapy? Okay.
Yeah. So this is how I explain it to patients, and I'll try to explain this pretty quickly. But what you're doing when you're using prolotherapy and you create that little localized injury in that area, what happens is that platelets actually show up to the site of the injury. They come and conglomerate. First of all, to stop the bleeding, right? That's, if you think about platelets at all, you're thinking of their ability to clot blood. But platelets have this whole other job to do in your body on the healing process. And so when platelets come and they granulate together to stop bleeding, they release growth factors. These growth factors are basically signaling cells to the stem cells, which actually reside on blood vessels as well. The stem cells, think of stem cells as kind of the worker bees that actually repair the tissue. They're unique cells that are capable of differentiating in different tissue lineages, meaning if you expose a stem cell to a ligament, it wants to become a ligament, tendon, muscle, etc. And so what you're doing is, and it's just like, as you said, it's kind of a progression. So if I'm putting an irritant in there to attract platelets, platelets are going to do their job, attract stem cells, and start that repair process. What we're doing with platelet-rich plasma is we're taking whole blood. So we do a blood draw, and we usually concentrate it about 10 to 12 times. So we spin it in a centrifuge. We remove a lot of the water content of the blood. We remove all the red blood cells. And so what we're doing is we're taking, say, 60 cc's of whole blood, spinning it down, keeping all the platelets from that down to maybe 3 to 5 cc's. And so what we're doing is when we go in and inject the platelets, we're fooling your body into thinking there's a massive injury there. In other words, we're not just relying on the circulating platelets to come and start that healing process. You're actually gaming the system, if you will, in a way, by bringing more that would ever go there on their own. And we know this is why we develop rotator cuff injuries, tennis elbow. I see the same things all the time, Achilles, plantar fascia, is because we know that the enthesis, or where that tissue attaches to bone, our blood supply isn't great. And so our ability to naturally get platelets to an area is going to be thwarted to some degree. And so that's why we tend to develop, these stubborn injuries there. And so what we're doing is we're just transplanting, in a way, platelets that otherwise would have a little bit more of a difficult time mounting that healing response. And so then the next step on the level would be, the final ingredient is, not only are we going to be, and I usually, when I'm doing a stem cell treatment, we're talking for really more advanced issues there, where something like prolotherapy or PRP might not be enough to get them there, high grade tears, and we can get into that. We're kind of taking all the ingredients. So I usually will do that, a platelet injection with a stem cell injection. So we're really taking all the ingredients. Not only are we putting this super abundant amount of platelets there, we're actually taking stem cells for where they're abundant. Remember, they're kind of the worker bees that actually repair the tissue, and we're putting those there as well. So we're not just relying on the native stem cell environment as well. And so that's kind of the thinking behind what we do there.
Yeah, that is so interesting. And you're totally right on the, we tend to develop these chronic tendon related issues in areas where the blood supply is not that great, right? And it makes sense that if that through the nutrients through the bloodstream is how we promote a healing response in areas that we don't get great blood supply, we're more at risk for having chronic issues that don't heal very well. So, and I think so many people on this listening can relate to having that chronic Achilles issue or tennis elbow or whatever it is, and they probably feel like they've tried a lot of different things, and maybe it improves, then it comes back down, then improves and comes back down, but they never quite, to use your term, like got over the hump of like getting this better for the long haul.
Yeah, another one that it's fresh in my mind now, Andrew, is that I've been seeing a lot, is another one that I see a lot in kind of middle-aged athletes in particular, is what we call a proximal hamstring injury. So your sit bone, where your hamstring tendons that run down the back of your leg, I would say outside of acute strains of like a mid-belly of a hamstring, I would say 90% of what I see in that long hamstring tendon is right there at that sit bone. Guess what? That's an area where it attaches the bone and the blood supply is limited. So it's a pattern we see, right, along the body.
Yeah. So I guess one question that maybe some folks listening might have is we had posed the scenario of somebody has an injury, or maybe it's a chronic injury, an issue they've been dealing with. They've gone to a place like Physio Room, right? They're participating in what I'll say high quality physical therapy, because we know that just like one provider isn't equal to another, like there are some lesser versions of PT out there and there's some better versions of PT out there, right? You could go to some offices where it's just clamshells on a table for weeks on end. You could go to others where, we're really trying to progress you back to the activities we're trying to do. We're trying to load you appropriately with a, progressive overload mindset. And some people respond great to that, and some are slower responders to that. And they might be improving, they might be getting stronger, but they're still having the pain, right? And I'd put myself in that category with my Achilles, right? It's getting stronger, I'm doing things, but man, that pain is still there. At what point, I guess where I'm getting at with this question is, at what point do people know, or should people seek out someone like yourself to consider some of these regenerative approaches to help them get through an issue?
Yeah, it's a great question. It's one that I talk to patients about all the time. My first thing that I offer all patients that have not gone through a good supervised physical therapy program is, to me, that's a must. And what I do is more akin to what you do than myself to an orthopedic surgeon. So I'm very, very much interested in the physical therapy world because of the great work that you do. And I tell patients, start there a lot of times, because a lot of good physical therapy can make my job somewhat obsolete. There are situations where, and I would say the majority of the folks that come to me have already done good physical therapy, and they have an injury they have an instability, or they have something that's just my rule of thumb is, if you've done good physical therapy for 3 months and you're still having issues, then it's probably time to try something different or additional to the physical therapy.
Yeah.
That's kind of my rule of thumb. I also get in situations where, someone's done physical therapy for a month and they're trying to get better for a race, at the end of the summer or something like that. What I tell folks is that I think I can help speed up their progress.
Yeah.
If they don't want to go necessarily, not the slow way, but the slower way. And there's some evidence we can get patients back to their activity of choice quicker. So it depends on the patient, I guess, is what it comes down to, what their goals are. You have some people that come in and like, oh, I'm scared of needles. No way. I haven't done I haven't done any physical therapy. And I was like, go do therapy, because you'll probably get better. And then you have other people say, I want to do everything under my power to get back to so I can get that race. And then we have that discussion. But generally speaking, if people have had good physical therapy for, I usually say 3 months, 6 weeks to 3 months, and they're not making progress, or they're not making progress at the rate that they are hoping to. And we always have to talk about realistic expectations with those folks. That's really where I come in.
Yeah. Yeah. That makes good sense, because regardless, I think in most cases of someone comes into our office or any other great rehab provider's office, there should be some progress that gets made. No matter how chronic your situation has been, if you're following the program and you're doing the things that the person has recommended for you and laid out based on your situation, right? It's not a cookie cutter approach. It's based on what you're dealing with. There should be some progress that takes place in those first 6 weeks. And if there's not, then we really want to start reevaluating things and potentially refer out, like you said, or figure out, okay, what's going on? What are we missing here? Maybe we misdiagnosed this issue and we need to reapproach this, because something should change pretty quickly if we're approaching it the right way. And where did this question go? What type of like, I know this, but I don't know if the people listening know this. What type of immobilization period, or is there an immobilization or a down period of time after participating in some of these regenerative approaches? Like, say somebody has, whether it's tennis elbow or Achilles or knee arthritis, and they participate in Prolo, PRP, or stem cell. What should they expect as, like, what's the course of that going to look like after they have it done?
Yeah, it's a great question. And my thinking on this has evolved over even the past year or so. Typically, if you're going to get one of these treatments, there's going to be a short period of immobilization, not so much to immobilize the joint or the tissue, but really when we're stimulating the immune system and doing these treatments, patients are going to hurt. And really, it's more for pain control than anything else. So let's say we did your plantar fasciitis. I'll probably put people in limited weight bearing for a few days and in what's called a cam boot. And I'll probably keep them in that boot for about a week to protect it and to help reduce the pain. For other patients, I just say activity is tolerated. I'm actually going more in that direction. I used to be really aggressive with, let's say we're treating a knee arthritis that had an MCL or medial collateral ligament tear. I was really probably over the top looking back on it with bracing and having them limited weight bearing and everything. And I don't really know what I was treating there. What I did see though is those people would atrophy pretty quickly. In other words, lose muscle mass, and it would make their physical therapy I think more prolonged than it needed to be. And so, like I said, I've evolved in my thinking more towards activity as tolerated, and then getting people into physical therapy within 5 to 7 days to at least get the joint moving, start isometric exercises, and then progressing from there.
Yep.
But if you look at the evidence in our world, people are all over the board when it comes to bracing and what the recommendations are. And I've kind of taken a step back and really want to get people moving as quickly as they can, as safely as they can, because I think at the end of the day, let me back up. When I do these procedures, patients are going to be in pain afterwards. There's no two ways about it. The typical amount of time, or if you think about it, you're stimulating inflammatory response, and that acute inflammatory response is about 3 days. And that's really where we're going to find the vast majority of your discomfort. Just like if you've had a surgery, the first 3 days kind of stink, and then it kind of goes down from there pretty swiftly. Same thing with what we do. And so I'm really doing bracing and protective weight bearing and things of that nature, or a sling for a shoulder, more so to help mitigate that kind of discomfort that they're having. But I don't want to do that for a prolonged period of time.
Yeah, that makes sense. And I think as a very general rule, of course, I'm not an orthopedic physician, but I think as a very general rule, that's kind of the trend that we have seen over my career, the 10 years that it's been, is I feel like protocols a lot of times from surgeons or from physicians like yourself, or even in physical therapy, stuff is progressing a lot faster now than it used to, all being mindful of like symptom limited, as tolerated, making sure we're not doing too much too soon, but trying to get people going quicker in the process to minimize things like loss of range of motion, atrophy, loss of skill development, or whatever that is, like you were mentioning.
Yeah, and like I said, people are all over the board. There are people that will, treat a rotator cuff tendinitis and inject Botox into the muscle so the muscle doesn't move at all because they're trying to protect a tear they treated. To other people that just say, no sling, do what you can. I don't think we have a right answer there, but like you mentioned, I just see it from the physical therapy standpoint and getting them back. If someone is in a sling for 6 weeks, and you probably see these in post-surgical patients, it's a steeper hill to climb,
Oh, yeah.
getting them back to activity. And I just don't know what, for what I do, what real purpose we're trying to serve. We're probably treating ourselves and our anxieties more so than the patient. And so I've become a lot more liberal and more aggressive in getting people moving.
Yeah, that makes sense. And one thing that you mentioned was this concept of like doing isometrics early to get that joint working and get the muscles working. And that is such a useful tool, and something that I forget when it was. I think I first learned about the benefits really of doing isometrics in a pain science course that I was taking, and how when we can get that tissue working, the muscles working in an isometric fashion where the joint is not moving, we can load that tissue to a tolerable amount. We can promote blood flow. We can facilitate like activity starting to happen without hopefully bringing on too much of the symptom. And while being mindful of like, we're still trying to let healing take place, but we're trying to minimize atrophy. We're trying to produce some pain relief, and you can really get a great pain relief effect from doing isometrics, assuming you're not doing them too intensely. And man, clients can often start that so early on in the process without doing any harm to the healing process that's going on. So yeah, I think it's a great concept.
Yeah, and one of the things, I'm not sure you do this or not, maybe you do, but one of the things that I like to utilize if it's available is things like blood flow restriction. So
Yeah.
you can restrict the blood flow to the area and really kind of stress the tissue without loading it so much, just continue stimulating that repair. And so it's a little trick, and I can't say that I'm an expert in it, but I like what I've read so far about that. And so there's ways that you can really be pretty aggressive on getting people back into the game without putting them at risk for re-injury. And that's just one that I personally am very intrigued by.
Yeah, I think blood flow restriction training, and from what I understand, a lot of a lot of the background of that came from folks that are dealing with amputations, and how do we load things when we're missing a portion of a limb. And I'll put a little plug in here for you guys if you've not listened to prior episodes of the code, but at Physio Room, we do have blood flow restriction units in our office. Episode 57 of this show talks about the science of blood flow restriction training. That was recorded probably like a year and a half ago at this point. And it was with a guy named Dr. Ben Weatherford. He's a PT with Owens Recovery Science, and they make blood flow restriction equipment. And we have one of their units, a Delphi unit in our office. So definitely check that episode out if you want to learn more about the details as it relates to blood flow restriction training. But it can be a great tool, a way to minimize atrophy, and a way to keep people moving at a lower intensity, but making that exercise feel very intense because you're restricting the blood flow. So you can get quite the challenging workout session with not a lot of load if you implement some BFR.
Yeah, I personally had it, and I was shocked about just doing, you know, 10 knee extensions. I was treating my knee meniscal tear after a PRP, and boy, it can make it really, you get a workout from doing something that seemingly is pretty innocuous or pretty simple to do. So and I noticed a difference, and I prevented atrophy and the whole deal. But great tool, and yeah, I'm glad you have a podcast on that. I'm going to check it
Yeah.
out.
Yeah, totally. Well, let me before we start the process of wrapping this up, I've told this story a couple times, but some of you know that I've been fortunate to deal with a long-standing Achilles tendinopathy, or like you said, tendinosis related problem myself. And I was training for a half marathon a few years ago, and I never did. People always ask me, well, when did you injure it? And I never really did have an acute injury of my Achilles. What I did have was, I think, an unnecessary orthopedic surgery back when I was in college. I had sprained my ankle very bad in football. And then I ended up seeing the orthopedic after the season and was told I had a bone chip in my ankle and that I needed to have it removed. Well, as I learned more and more and more, this was not a bone chip from rolling my ankle. This was a little bone projection that was in there all along. And I probably did not need that surgery. And it was after going through the casting and then boot process after that surgery that I really remember developing tendinitis in my Achilles in the first place, right? So I started having this Achilles issue because I was trying to get back to activity quickly because I was in between my final season of college football and college track and field. And I was hoping to still run track. And so long story short, I developed Achilles issues, and I really wasn't even referred to good physical therapy until I asked to go to PT. The surgeon did not recommend that I go to PT. Now that I know the things I know now, man, it was like not even a question. I had such bad ankle range of motion after coming out of that cast and stuff. It really shouldn't even have been a question that I needed rehab. But like I said, I wasn't through physical therapy school at this point. So I didn't understand how to rehab this myself. And I never really did give it much of a proper rehabilitation process. And I just kind of dealt with this, up and down Achilles issue for a number of years. And it was never really bad enough to force me to like do anything about it. It was there, it was sore. I would warm it up, I would do some exercises, it would feel better. And I just continued on with all the activities I was doing. Well, fast forward several years. This was 2013 when I had that surgery. Now it's 2021. I'm training for this half marathon, and I'm getting to like the peak part of the training. And man, my Achilles is really starting to cause me a lot of issues, to the point where it's now really negatively impacting my running. I'm spending more time trying to recover my Achilles than actually training. And after that race, I ended up having an MRI. Based on the results of that MRI, it showed significant tendinopathy, or like chronic tendon degenerative changes from impaired healing, and a small tear. And then Dr. Kevin here was actually the one that pointed out, because this wasn't in the report, that I also had a tear in my soleus muscle, which is the more important of the two calf muscles when it comes to running and closed chain activities where you run around on your feet. And that wasn't in the report. So we ended up doing a course of treatment that involved PRP, prolotherapy, things to try and facilitate a healing response to this Achilles. And I had actually already had some PRP injections before Kevin and I met. And then we ended up doing that with just a much more stronger dose, or a stronger treatment. And then we won't get into it on this show, but we also included a treatment called 10X, or like a scar tissue removal procedure on the Achilles to try and get some of that damaged tissue out of there, lay in the PRP and promote that healing response, and let the body try to facilitate that healing that has been lacking for so long. And I'm happy to say that I just ran 5 miles yesterday, and that's the first time I've ran 5 miles in 2.5 years. So though it was a very slow going process from the get-go, and like Kevin said, there definitely was pain involved after I had that procedure, and there was an immobilization period for a few days. I'm doing more activity now than I've done in the past few years, and it's really cool to see this this healing process starting to take place. And then we actually did a repeat imaging MRI on the Achilles just a couple months ago now, and the tissue looks better. I still have like a thickened Achilles, like it is still thicker than the other side. And if you looked at my two ankles, you can really notice that. But the quality of the tissue on the MRI looks better, right? Like you don't see the tear present there anymore. You don't see as much of that scar tissue, tendinopathy in there. There's just a lot more tissue present. And I really think we're continuing on the path of seeing this thing continue to improve. So if you're somebody that's been dealing with a chronic issue, you feel like you've tried things and you've actually tried what we'll call good physical therapy, right? Not YouTube physical therapy, not doing a couple exercises that your friend gave you or something like that, but you've actually been through a course of supervised PT where you're working with someone who is focused on you and they're not trying to juggle like 7 patients at once, I think it would be appropriate to look into some of these things if you've been dealing with one of those chronic issues to get over the hump so that you can get back to doing the activities that you really want to be doing. Because we talked briefly about longevity and just continuing to scale back the activities that we do because stuff hurts and doing less and less and less. To me, and probably most of you listening to this, that's just not really an option, right? Like, not running was not an option for me. And I had multiple providers tell me, even other PT colleagues, well, maybe you should just stop running and do something else instead. And I said, well, no, because I want to run and we're going to have kids and I want to chase them around. And like, running is just something we need to be able to do if I want to live what I consider a fulfilling life. So yeah, I think checking out these types of procedures would be very appropriate, or these types of treatments, I should say, because like you said, so many people want to avoid surgery when it's not necessary and get back to the things they want to do.
Well said, man. Yeah, well said. I still think we have a little bit to do with your Achilles, but I'm glad to hear that you're becoming more functional. That's a tough nut to crack in a lot of patients, is that Achilles tendon. It's the bane of a lot of our existence, but we eventually get people there for sure. And thank you for sharing that.
Yeah, absolutely. Well, I want to make sure, Kevin, before we wrap up, that people know how they can get in touch with you guys at Breakthrough. So what are the best ways for people to, and we'll put this in the show notes and everything, what are the best ways for people to get in contact with you guys if they have questions that were sparked by this conversation so that they can get some answers to those?
Sure. So we're at Breakthrough Regenerative Orthopedics, and it's 5161 East Arapahoe Road, Suite 250 in Centennial. Our number is 720-463-0567. You can find us online at orthopedicscolorado.com. Quick Google search for Breakthrough will also get you there, and we'll take good care of you.
Awesome. Awesome. What else? Before we're about to wrap it up, but was there anything that you think we forgot that we need to mention before we close her out here today?
Yeah, I mean, I think we touched on a lot of things. If you come to see me, I'll talk to you as much or as little as you want to know about the science behind things. I will say this, with regenerative medicine, it became very popular probably about 10 years ago. And there are a lot of people that still practice or did practice regenerative medicine, quote unquote, that were just sort of dabbling. You can go to your local orthopedic office and there's probably somebody there that will give you a PRP injection. But those of us who do it well and do it for a living, and that's all we do, we're really into it. We really understand the science. We understand the latest techniques. And so what I'm trying to say is that not all regenerative medicine is created equally. And so I'd be very discerning about who you see, what their training is, what else they do, because a lot of people jumped on the bandwagon that quite frankly shouldn't have been doing it at all, and gave a lot of people a sour taste in their mouth. These are not covered by insurance, generally speaking, and people are out to just make a quick buck. And it's really something that's a thorn in my side, that people, they say, oh, I got a PRP and it didn't work. And I get a fuller understanding of exactly what happened. And a lot of it was done inappropriately. So please, if you don't come see me, come see somebody that has the appropriate training and that knows what they're doing, and preferably does this for a living and not as sort of a side hobby or job, because you can't do this effectively and completely for patients if you're not totally invested. This is a whole scientific realm of orthopedic medicine that is changing daily, and you really need to keep up to date and have the appropriate training. And so that would be my last words on it. And I'm happy to see any of you out there that want to improve their performance or get over the hump with injuries. About 80 to 90% of things that come through an orthopedic surgeon's office do not need surgery. And a lot of patients aren't aware of what we can do. And so, clearly, if something is clearly surgical, I don't want to do a procedure on somebody that's going to be inappropriate and have them ultimately dissatisfied when they were better suited for surgery. And so I'll have that discussion with you as well. That's always an option for you. But fortunately, a lot of times, most times, vast majority of times, I'm able to help.
Yeah. Amen. Amen. Definitely find the provider that is well suited to be dealing with what it is you're dealing with, and find someone who's an expert to get you back to the things that you want to get back to. Appreciate you guys tuning in to this episode of The Code. Dr. Kevin, thank you so much for joining us and sharing all this information with us today.
Thank you, Andrew.
Absolutely. You guys, you've heard me say this before. If you've listened to other episodes of The Code, if this is your first one, you'll hear me say it now. We're trying to get this podcast out to more and more people. If you've not already done so, man, a review would go a long way. Whatever podcast platform you are listening on, scroll to the review section, drop us a 5-star review on there, and help us get up to 200 5-star reviews so we can spread this show out to more and more folks. Thank you again for tuning in to listen to this episode of The Code, and we hope to catch you guys on another one soon. We'll talk to you later.